So welcome to the webinar, Clear Aligner Treatment Plan Reviews, What to Look For and Why. The lecture will be presented by Dr. Yaman Tahane, and we will begin shortly. And now it is my distinct honor to introduce Dr. Yaman Tahane, DDS. He graduated from the University of Jordan with a diploma in primary care dentistry and specializes in clear aligner therapy. As a clinical success specialist and educational consultant, he has overseen hundreds of cases, published articles, and collaborated with global experts to advance knowledge in dental technology and clear honors. And now it is my honor to say, take it away, Dr. Yaman.
Thank you, Jessica, for the introduction. And good afternoon, everyone. Welcome to the third webinar in our series. So I'm pretty excited about this one. We've covered two webinars so far, me and my colleague, Dr. Farah, over clear aligners. And for this third webinar, I'm pretty excited because we get some really practical information in this one that you can apply right away in your practice. So just to start, I need to disclose that I am an employee of Eon Dental. So this is the presenter and commercial support disclosure. And this is our lecture overview. We'll go through a systematic framework for evaluating clear aligner treatment setups. One of the learning objectives, we will go over step-by-step approach to review clear aligner treatments. We will learn how to spot essential issues in staging and movement sequencing. We will identify and verify appropriate attachments, IPR, auxiliaries for each case. And we will determine how to request specialized auxiliaries. And we will compose concise, effective notes to communicate feedback and request modifications to the technicians. So first of all, for this lecture, or whenever we get to the, let's say the video or the 3D simulation of the treatment setup, it's basically the essence of our whole plan for clear aligner treatment. It's the way that we communicate with the technician and the manufacturing, so we can get the plan that we want and we get the results that we want in the clinic. So I like to use this analogy of comparing the doctor to, let's say, a football coach or any sport. The coach always has a playbook, a plan for the game, and then the forces or the players always need to execute the play according to the plan. And when you're designing the case before it begins, just a second, this is just covering my way. I need to move this window. Yeah, I was saying, so you are the coach designing the play before it begins. And the 3D simulation is basically your playbook, your plan for the game. It outlines every move or force you're going to apply to the teeth. And once you approve the plan and the aligners are manufactured and inserted into the patient's mouth, it's like the ball snap, and it sets your plan in motion. So success on the field or in your treatment setup will depend entirely on the quality of your initial design or your initial 3D simulation of the treatment plan. So we're basically for treatment planning or the importance of the staging or reviewing the treatment plan, I don't think we need any, like we have loads of literature covering this, and we don't need any more evidence over that whenever we can go. So for example, here we have a published article by Stephen J. Bowman, and it always says, you can find it in many articles, that simply expecting teeth to move from start to finish according to the 3D simulation. Sometimes we get a lot of doctors that apply what I call like cartoon orthodontics. So they basically just move the teeth on the simulation until they get to an ideal alignment or a beautiful final setup. But this will only look good on the viewer. This might not always translate clinically. So in order to be able to understand how these movements are going to translate clinically, we need to go by our checklists or the way that we can go over a treatment setup, stage it properly, and make sure everything goes according to plan. So for the lecture outline, I have these like the coach 3 rules for every treatment setup. First of all is predictability. So the playbook, we need to understand that the playbook isn't always the player. What we see, this is something we've previously mentioned, what we see on the treatment simulation is not what's going to translate clinically until you understand that what you see in the simulation is a representation of the force system, not the movement itself. So when you see the teeth moving on the treatment simulation, it's not the teeth that are actually moving, it's the plastic of the aligner and how it's going to cover those teeth and how is it going to apply forces to those teeth until we reach the final needed position. Secondly, staging is everything. Staging is what determines whether a certain movement happens or not, because when we stage synergistic movements together, we're more sure that they're going to be more predictable. And whenever we have antagonistic movement, we need to expect that we're going to have some sort of loss of tracking. And finally, there is always a checklist that we need to go over whenever you want to approve a plan, whenever you're okay with everything, you need to run your final checklist to make sure you covered everything before approving any plan for manufacturing. So starting with the predictability, we can again cover that the simulation shows the perfect route of teeth. So the simulation is going to show how the teeth are going to move from initial position to final. Your job is to remember that the tooth is this plier facing real world resistance. It's not always as perfect as the plan. So whenever you see a tooth movement that's going smoothly on the viewer, it does not necessarily mean it's going to translate clinically. So the 3D setup shows the changing shape of the aligner plastic, not the guaranteed tooth movement. And there is this idea that we shared before. So in any webinar or any, let's say, educational forum about clear aligners, you're going to always hear them say that the clear aligner treatment setup or the 3D simulation is a representation of the force system, not the actual clinical outcome. And this might be true to a very big extent, but I always like to think about it as a spectrum. So depending on the case severity or the movement needed or the type of movement, whether it's predictable or not with aligners, you can go from the 3D simulation being a representation of the clinical outcome whenever we have, for example, spacing cases or an open bite. These are more of the more predictable cases to be treated with aligners because we have some spaces to allow plastic wrapping of the aligner and applying all the favorable forces. But whenever we go to more difficult cases, like deep bite cases or cases with extraction, these you'll have to keep in mind that the 3D simulation is going to be a representation of the force system. So we're always, because in extraction cases, for example, we're gonna have to move teeth for bodily movement for big amounts or a big number of millimeters. You're gonna expect that you're gonna get some tipping, unfavorable tipping, because bodily movement is always challenging with aligners. So you'll need to account for that in your 3D simulation to expect that the outcome needs to be overcorrected. So for example, if we look at a more predictable type of case, this is an open bite case. And in the simulation, we finished the same way as you see in the picture below. We finished with this final result on the simulation. And because it is a predictable type of movement, and because it is one of the more favorable types of malocclusions to be treated with clear aligners, you're going to get the results very similar to the simulation. In contrast, if you're treating a case with a deep bite, which is more difficult, deep bites are difficult because we always have this intrusive effect of the clear aligner on the posterior teeth, and also anterior intrusion is limited to a certain amount that might not treat all deep bite cases. So whenever you're treating a deep bite case, you'd always want the simulation, the 3D simulation, to finish with an overcorrected edge-to-edge or open bite, similar to the picture on the left below. But when we overcorrect the treatment, when we get this result on the simulation, we're going to expect to get a better final result clinically. That is actually where we want to reach. So that's it for predictability. Moving on to staging, it's important to understand that staging refers to the strategic sequencing of teeth movement throughout the treatment. This process involves dividing the planned movements. We don't want all of the movements happening at the same time. I don't want to be solving anterior crowding at the same time I'm doing extrusion or intrusion on posterior teeth. The aligner is going to be overwhelmed by all of these forces, and one of these forces is not going to track. And when one of these forces, like the easier force, is going to track and the other one is going to be hindered, and this is going to end with loss of tracking and the aligners not fitting in the patient's mouth. So what we do is that we stage the movements, we divide them. So again, we divide the planned movements into a series of steps, with each aligner facilitating specific adjustment. So each step or aligner is going to be aimed at moving or for a number of movements that are predictable or synergistic together. The goal here is to ensure that forces are applied effectively, safely, and optimizing the treatment outcome. So why is staging important? Clear aligner therapy. We have multiple reasons. First, it creates space for tooth movement. So clear aligners operate in a closed system. Any undesired movement, like the watermelon seed effect, may occur if there is no sufficient place in the arch. So for example, I want to do some rotation on the anterior teeth, but I don't have enough space for that. So I'm going to stage my movement to do some proclination, to create spaces, or expansion posteriorly to create spaces between anterior teeth. Then I will apply the forces needed for rotation. If I do that all at once, if I procline the teeth and expand and rotate the teeth all at the same time, and I don't have sufficient space for these rotations to happen, because the clear aligner is a closed system, it's gonna apply an unwanted effect called the watermelon seed effect, and it's gonna cause unwanted intrusion to these teeth because it's trying to rotate the tooth and there is no space. So it's like holding a watermelon seed between your fingers. It's going to slide. It's going to slip between your fingers or from the aligner and intrude into the bone. So this watermelon seed effect may occur if there is no sufficient space in the arch. We need to ensure we always create space when planning. And again, our space provision methods is either posterior expansion, proclination of the anterior segment, interproximal reduction, distalization of the posterior segments, or finally, in the most severe cases, extractions. Second of all, it ensures proper force distribution. So aligners rely on push forces to apply pressure. Forces can become ineffective or lead to loss of tracking without proper staging. Again, this is what we said. Staging helps balance differential anchorage. So whenever we're moving a segment of teeth, the aligner is going to need anchorage from other teeth in order to apply this force. If we are moving all the teeth at the same time, we're not going to get a segment that is stable and providing anchorage for the other movements. So if you're moving the posterior teeth and the anterior teeth at the same time in unsynergistic fashion. So in some movements, we can combine anterior and posterior movements in a synergistic fashion. But whenever it's unsynergistic or these are unfavorable or contrasting motions against each other, we're not going to have enough anchorage to apply the movement. So we need more teeth to remain stable as anchorage, and we need to target the movement on certain teeth in controlled increments. Lastly, it prevents unpredictable movements. So without proper staging, movements can become antagonistic. For example, posterior expansion, and this is what I was just talking about, posterior expansion and anterior protrusion, these are opposite forces. So if we're doing both of them at the same time, we're gonna get we're gonna get bad movements in both the expansion and the proclination. However, if we go and let's say we do constriction of the posterior segment, we can apply anterior protrusion more effectively, because if you imagine how the aligner, this is the pearl necklace analogy. If you imagine the aligner as a pearl necklace, if you push the sides, the front side is gonna go back, and this is gonna be the retraction of the anterior teeth. But if we want to do anterior protrusion, we're gonna need to constrict the sides or the posterior segments. Also, rotation and extrusion. So the aligner is going to struggle to generate the proper forces to plan both movements at the same time. So we need to separate the vertical movements from rotational movements needed on teeth. Lastly, applying all the concepts that we just talked about staging, this is all going to accumulate and result in reduced refinements and treatment time. Whenever we stage the plan properly, we're going to need less refinements, and this is going to translate into less aligners, less, let's say, less cost and less time for both the patient and the doctor. So whenever you're a general rule you can go by is like you have to have a structure similar to treating the transverse malocclusions first, moving to the sagittal or the anterior posterior, and finally moving to the vertical correction of the malocclusion. And now we get to the juice of this lecture, which is your treatment setup checklist. So in your checklist, first, these are the 6 factors that we need to go over. It's the bite. We need to confirm the bite. Then we move to the final result. We check the staging, the attachments, interproximal reduction, and alignment. And I know this might all does not make sense right now, but once I go with you systematically over how to review a treatment setup, you're going to understand the most optimal way to go over your plan. Of course, you can change the order and play around with it. This is the way that I've found most effective, not to miss anything in your treatment setup. is that you go by this order. First of all, we need to check the bite. So whenever you've took scans and bite registration, you've sent it to the lab or your clear aligner provider, and you've got the notification that your treatment setup is ready. The first thing I need to do is to check if the bite from the whether the bite registration that I took or the intraoral photos matches the bite in the 3D simulation. Because when exporting the scans and exporting the bite registration, you're always gonna get sometimes maybe the softwares are incompatible. We're gonna get issues sometimes with the bite. So before anything, before wasting my time and going through a plan that is based on a wrong bite, this is gonna cost me like even of course if I miss that this is a wrong bite and I approve the plan, I'm gonna get unfavorable movements in the patient's mouth, and I'm going to get with results that are far different from reality. So we check the bite from the front and the side views, comparing it to clinical photos, and checking the anterior overbite, anterior posterior relationship, and the interdigitation. So what I like to do is, like, because the 3D simulation can be moved around, I like to make sure that the angle that I'm looking at from the 3D simulation matches the angle that was that the intraoral photos was taken at. And this is going to help me if the bite is 100% identical to the 3D simulation. Second, after viewing the bite, after confirming the bite is correct, I move to the last step. I go and check the final result. So I can get into staging because, for example, I'm going to have a treatment setup with 30 aligners. If I start looking at staging and wasting my time with the staging of this and that, I might miss that the final result that the technician viewed for me in the 3D simulation is not the final result that I want. So all this effort that I'm going to put into correcting the staging or writing notes about the staging is going to be wasted, because when you change the final result, you're going to need different staging based on that. So I always go to the last step. I check the final position and the movement protocol. So movements planned from 0 to the final setup in the 3 dimensions should be reviewed and checked. This includes the final position, as I said. Then, after checking the final position, confirming everything is that this is the final result that I want to reach, I can check each movement separately, and we then connect these movements to check the interactions of these different movements, whether they're synergistic or antagonistic, and we check for movement compensation, or what we call overcorrection. So for example, in an extraction case, I'm moving a tooth and I'm moving it bodily for a big amount. So for example, even without extraction cases, if I'm distalizing a tooth in a spacing case, and I'm planning a lot of bodily movement, I'm going to expect, because the aligner has this grip over the tooth and we always get this stepping side effect, the tooth is not going to move straight like this. It's always going to tip while moving. So to make sure that it does not tip, I overcompensate in the treatment setup. So instead of it moving like this in the treatment setup in a bodily fashion, I want to compensate. I want to add some tipping in the opposite direction so I can compensate or overcorrect the movement or the side effect that I'm expecting. So always stay systematic in order not to miss anything. For everything that we're going to check, find your own way, find your own order, but always go through it as a checklist. Stay systematic. I like to check the frontal result. Then we can check the right and left views of the 3D model. And then we check each arch separately throughout the occlusal views for the upper and the lower arch. So the final result is the last step of the treatment setup. So if it's 30 aligners in this treatment setups, I go directly to step 30. And this is going to be after completion of all the alignment. This stage should be checked first from all views to make sure, like, what do I look for? Have the treatment goals have been met? So for example, if I want to correct a case of protrusion, the patient has protruded teeth, and in the final alignment, I see a beautiful alignment, all the rotations have been fixed, but I did not get enough retraction. I need to check that first, because this changes the whole plan. My main goal, or like the chief complaint of the patient, is that the teeth are protruded and the patient would want them to go back. So first of all, we need to check if the treatment goals have been met. And second of all, is the total amount of movement predictable? So for example, if I want to retract teeth, but I get the setup and we're retracting more than like 5 millimeters of retraction, I'm going to expect that this is not a predictable amount of movement within clear aligners. When I move teeth this much, I'm going to get unfavorable movements or loss of tracking, because of course we have biological limits, we have limits of the appliance itself, and we have aesthetic limits actually for the movement itself. I don't want to overdo any movement in order not to get unfavorable results in the end. Second of all, this is the third point. So first of all, we check the bite. We make sure the bite is correct. It matches our intraoral photos. Second of all, we go to the final result. As I said, we check from different views. And in the third stage, if I'm okay with both of those, we can go to staging. So for staging, we have factors to consider during the evaluation, and staging includes special protocols. We have synergism between certain movements, we have antagonism, and as well as the movement taking place, the following is evaluated. So we evaluate each movement separately. We evaluate the interactions of these movements together. So when I say each movement separately, I'm saying look at the movement, look at when it started happening. If we want it to happen this early, for example, do I want to start with this vertical compensation so early on, or am I going to leave it last after I finish the transverse and anterior posterior problems? So we look at these movements, we look at the amounts, we look at when they happen, and we check if these movements are predictable or not. After I check each movement separately, I need to start noticing, are these movements that are happening at the same time are going to be synergistic, meaning they're going to complement each other, or are they antagonistic, like physically the aligner is not going to be able to apply all these forces at once, and it's going to be overwhelmed, leading to unfavorable results. And lastly, again, is movement compensation, and we talked about that before. So similarly to the final result, also the movements, I go over them in a systematic approach. So I check the whole video, the movement itself, from the anterior view, from the left views, and then from the top views. So making sure every time I'm replaying the video of the movement, I'm looking at a different thing. Even when I'm looking at the occlusal views, for example, for the upper and lower, I like to separate. I play the video once, concentrating on the anterior movements, and then I play the video again, looking at each posterior segment alone. So going over that in a systematic manner is going to make sure you're not going to miss any movement, because trust me, if you've seen any 3D simulation of a clear aligner treatment setup, once you press play, you're going to be overwhelmed by all the movements happening at the same time. So if you don't concentrate where you're looking at in each play, you're going to be wasting time. You're going to be missing certain things that, or going to simply forget about checking certain movement or certain views. So for example, from the upper and lower occlusal views, if we play the video, let's just go over them and check play. So for example, in the first play, we're going to see the teeth movement. I want to concentrate that the posterior segment is expanding, and then the anterior teeth are retracting. And this is something, when I look at the treatment setup like this, I directly can tell that this staging is not the most optimal staging, because as we said before, expansion and anterior retraction are synergistic movements. So in this case, I don't see the point in separating them because they complement each other. Instead, I would start with anterior teeth proclination in order to derotate the teeth. And then once I'm done with that, we can do some round tripping and bring the teeth back, retract them with expansion. And this way I can be sure that these movements are synergistic together. So we look at the movements in the transverse plane. We notice how the expansion is going on. We also, from this view, it's good to notice the contact areas. So in the end result over here, I can notice, I'm sorry, I can go back to the video. I can notice that, for example, between the anterior teeth, the teeth are moving, but I'm seeing a little bit of collision between the contacts. These collisions means that this movement is not going to happen. The tooth is going to want to move like the video in an optimal direction. But if we don't create space first for this movement, I'm going to get a block and I'm going to get loss of tracking. Or in the worst case scenario, I'm going to get unfavorable intrusion as the watermelon seed effect. So it's important to look at the transverse plane, the expansion, the contact areas. I can view them from this view easily and can tell if these contact areas are appropriate. For example, in the video below, I can see that we took interproximal reduction. So the collisions that are happening between the contacts are okay because I took interproximal reduction. I'm going to have spaces in the real life clinical scenario, unlike the 3D simulation where I'm going to see the teeth colliding between each other. And of course, when we can check from the occlusal views that if we have any residual interdental spacing, we're going to see amount of the rotation that is achieved. So for example, if we look at the lower arch, the canine is really rotated. And if I'm looking from the frontal view, I might miss if the rotation that is happening is enough. So from the occlusal view, I can actually tell what's the amount of the rotation that happened on this tooth and when the rotation took place. So for example, if rotation took place with other movements, I'm going to be a little bit skeptical of this rotation happening. And lastly, we can view the arch symmetry and shape. So this is for both the staging and the final result. All of these aspects that we can check from the occlusal views. Second of all, the frontal view also allows the evaluation. So after finishing viewing the occlusal views, I move to the frontal, and then I can check the following. I can check the mesiodistal tipping happening on the crowns, because if we go back to the occlusal view, you're able to see the rotations, but you're not able to see the tipping. These teeth in the video are undergoing significant tipping that I can only notice through this video. And it's important to check also, similarly to the idea of rotation, it's important to check if this tipping is happening with space available, or is it going to result in collisions between the teeth and blocking of the movement in the real life clinical scenario. Also, I can check the intrusion and extrusion. When are they happening? When are these vertical movements happening? And we can check the changes to the anterior teeth, whether we have any overbite changes. So for example, in the previous cases that I was showing, in an open bite case or a deep bite case, we want to overcompensate and finish with an open bite or edge to edge. We can check that too from the frontal view. And we can notice also the midlines, if the midlines are changing. Sometimes technicians mess that a lot. They aim to reach the final position with good alignment, good rotations, but they miss out that we can actually shift the midline into an unfavorable way that is going to be annoying to the patient. So it's really important to check any midline changes that are happening during treatment. So I'm talking about the dental midlines between the central incisors in the upper and lower arch. Also for staging, from the side views, we can find the canine and molar relationships, because sometimes solving these crowding or solving any issues, the technician might not take notice that they're worsening a good canine and molar relationship, or they're worsening a good occlusal interdigitation, or lastly, the overjet. So all of these can be evaluated from the side or buccal views of each side. Really useful also is to check each arch on its own, especially when we have a case of deep bite. The lower teeth are going to be covered by the upper arch. So in all of clear aligner providers, they allow you to check each arch separately, and checking for the torque changes in the anterior teeth. We don't want a lot of unrealistic torque to be applied, because as we know, torque is a difficult movement to apply with clear aligners. In ortho in general, it is a difficult movement to happen. So if we're doing a lot of torquing movement during the treatment setup, we need to take a pause, evaluate, and understand if I just want a beautiful result on the simulation, but when I apply this much torque, it's going to be overwhelming for the aligner. The aligner shape is going to change, but it's not going to translate to a change on the tooth movement. And this is going to result in loss of tracking, or like as we usually say, like ill-fitting of the aligner. We also can, once we check each arch alone, we can check the curve of SPI, because sometimes we need to reverse or correct the curve of SPI, whether by leveling or reversing it in deep bite cases, to improve the vertical dimension for the patient. So again, I can check all movements from the side views, and I can check it for each arch separately. So what do we keep in mind when looking at staging? So we look at the sequencing and timing of movements. We look at the rate at which movements take place. The sequencing and timing is, we went over it multiple times. We want to start with transverse, anterior, posterior, then vertical. Sometimes we're going to go against this order, whether it was for aesthetic concerns for the patient itself. When the patient wants to start treatment and they have an open bite, they want the chief complaint to be treated as early as possible. And this is important to keep the patient compliant, because if the patient is wearing many aligners and there is no improvement happening anteriorly or to the chief complaint that the patient is suffering from, you're going to lose compliance, and this is going to affect the overall treatment. So sometimes it's okay to go against the usual order in order to address the aesthetic or chief complaint of the patient, and this will reinforce the patient's compliance and reinforce the success of the treatment overall. Second of all, after checking the sequence and the timing of movements, we look at the rate at which the movements take place. For example, if the tooth is moving at a higher limit to stay in a lower number of aligners, this is sometimes what technicians do. So they don't want to give you or show you a long treatment setup with like 30 plus aligners or 40 plus aligners. So what they do is that they move the teeth at higher rates, and you need to keep an eye for that. You're the doctor, you're the treating doctor, and if the movements or the teeth movements start happening at a higher rate than they're supposed to, you're going to get loss of tracking. This is going to translate with unwanted movement, and it's going to be a bad experience for you and the patient. So always make sure not to rush any treatment. Make sure all the movements are happening at the right time and at the right rate of movement, because otherwise, if you rush things, you're just going to need to do another refinement, another mid-course adjustment, and you're going to end up doing a longer treatment than actually going by the normal rate. And lastly, while you're staging, you're going to keep in mind that we have both arches moving at the same time. So sometimes the technician is going to miss that some interferences are happening between the opposing arches. You need to keep an eye for that when you're checking the staging. So as you can see here, this is something that is provided by most clear aligner providers. Once you check the tools in the 3D viewer, you can check the teeth movement table, and the teeth movement table contains the rate of movement or the amount of movement per step, and for each arch differently and on each type of movement. So for example, over here, I can see that I'm getting all the rotations are happening are less than 1 degree. And in clear aligner treatment, we can go up to 2 degrees per aligner. So I can know that rotations are happening at a normal rate. Similarly, I can look, for example, at the translational or bodily movement. They're all minimal numbers. We're not going over the limit, which is 0.22. So you can find these rates of movement, and they're out there in multiple studies. And I think we have a slide that includes that. We already covered it in previous lectures. You can go back to these rates of movement, the normal rates of movements that you can find and check for every treatment setup to make sure that your teeth are moving at a realistic rate. And it's not just that a cartoon of teeth moving into an ideal position, irrelevant of the rate of movement or the accepted speed of movement for these teeth. Also, one of my favorite things is synergism. Once you master planning these movements together at the same time, you're going to get the most effective results. So for example, if I'm doing posterior expansion and I'm going to need anterior retrusion, I always avoid doing proclination of the anterior teeth with the expansion. I delay the expansion, I procline the teeth at first, and then when I want to bring them back after derotating them, I combine it with posterior expansion. This way I can make sure that the synergistic movements are happening at the same time. Similarly, if we're doing derotation plus expansion or distalization for posterior teeth, if I'm distalizing the tooth, I can derotate it in a favorable manner at the same time to make sure that I'm not separating these movements and consuming extra aligners. These are movements that are okay to happen together. When I'm distalizing the posterior segment, I can fix the rotations while distalizing. Similarly, when we talk about posterior expansion and anterior retrusion, we can reverse that and think of anterior proclination or anterior protrusion is always good to be combined with posterior constriction. Just keep the pearl necklace analogy in your mind. Imagine the teeth from the occlusal view as a pearl necklace. If I push the sides, the front side is going to go back. And if I push the front side forward, the sides are going to come in together. So this is the easiest way to remember it. And of course, whenever you can imagine that I'm applying anterior intrusion on the anterior teeth. So I'm intruding this part the posterior part is gonna want to go out. Like for every action, there is a reaction, and this reaction is gonna be favorable in our case. When we're doing intrusion of the anterior segment, the aligner is going to want to let's say go out posteriorly, and this going out is going to be favorable for us because it's going to apply the extrusion needed. So also when we're doing molar distalization, so I'm distalizing the posterior segment, the reaction of the aligner is going to be to push the anterior teeth. So if I'm doing both of these at the same time, we're going to know that we're going to get favorable results. And similarly to what we said, if we want to intrude the posterior segment, the anterior segment is going to want to go down, and this is going to help us combine posterior intrusion with anterior extrusion. This is really helpful in open bite cases, and you're going to see it works like magic. Aligners close open bites really quickly because all of these movements that are synergistic together. Most importantly, I think this is more important than synergism, is avoiding antagonism, because antagonism is always going to lead into loss of tracking. If I have a plan where I'm doing a lot of anterior protrusion and posterior expansion at the same time, like if you imagine the way this, like if you look at the photo over here on the left, upper left side, and you just imagine how the movements are happening, you're going to come to the conclusion that there is no anchorage in this case. The teeth are all expanding at the same time, and we don't have anywhere for the aligner to depend on for the anchorage. So of course, some of these, or like most of these movements are not going to happen according to plan, and you're just going to end up wasting time. Similarly, derotation and extrusion of every single tooth. So I can't derotate a tooth and extrude it at the same time. These are like opposing surfaces that we're going to apply forces on. So it just does not make sense. You need to separate extrusion of any tooth from the derotation. Similarly, posterior compression. If the aligner is going to compress all the tooth at the same time, we're not going to have sufficient anchorage to depend on. And we can go over all the others. If I'm extruding all the teeth at the same time, I'm not going to expect any extrusion to happen. If I'm intruding all the teeth at the same time, anterior and posterior, I can't get any anchorage. The aligner is not going to be leaning on any tooth to apply the movement because they are all being intruded on the simulation. So it's basically the aligner just being passive on the teeth. Similarly, molar distalization and retraction of the anterior teeth. If you do that together, I've seen it hundreds of times, the distalization is not going to happen. It's simply going to get loss of tracking, and the aligners are going to stop fitting. So make sure molar, when you're distalizing the posterior segment, that the anterior segment is not also coming back at the same time. And this is why when we're distalizing teeth, we use something called the 50% protocol, which is if I'm distalizing the last molars, I don't move the tooth after them until the first tooth that I started moving reached halfway through the final position. Once it reaches the halfway to the final position, I can start moving the next tooth. And once it reaches the final position and the other tooth goes halfway through to the final position, I can move the next tooth, and we go on until we move all the teeth. This is why distalization cases are usually high in the number of aligners and the treatment duration, because we have to separate the movements according to what I just explained. After checking the staging, we've gone through the staging, we've gone through the hard part. So again, we check the bite. I start out by checking the bite. I check the final result. I go systematically through different views and look at different segments each time. Similarly, I go to the movements. So I look at each view, frontal, buccal views, or occlusal views. I keep replaying the video and looking at the movements while they happen, and I look at each segment differently. I check the movements that are happening, whether they are predictable, whether they make sense, and whether they work with other movements synergistically or antagonistically. I need to keep anchorage in mind. Whenever I'm doing a movement on the anterior teeth, I need to ask myself, where is the aligner leaning on? And where is the anchorage coming from to apply this force? If the teeth are moving posteriorly in an unfavorable manner, and I'm also moving the teeth anteriorly, the aligner is not going to have sufficient anchorage to apply forces. So after checking the staging and the movements, we reach, we've covered 75% of the clear aligner treatment setup. I can finally start looking at attachments. So what do I want to check for attachments? First of all, I need to check if I have a sufficient number of attachments for retention. So, for example, if I have a long posterior segment, I have all the 8s fully erupted, and I don't have attachments for the 8 or the 7 or the 6, all the 3 molars don't have any attachments. I'm gonna expect the aligner to be loose and flappy from this side, and this is gonna be really annoying to the patient. So sometimes we need passive attachments that only work for retention to make sure the aligner is not loose and annoying the patient. And because whenever the aligner is loose and not retentive, it's not gonna be able to lean on teeth and gain anchorage from them to apply force on the other teeth that are actually moving. So I need to check the number of attachments. I need to check if I have enough retention in each segment. I need to check the type of attachments and if they're relevant to the movement. So for example, we can go over the attachments later, and we've also covered them in the first webinar. If you missed the first webinar, I encourage you to go back and check, because we talked about attachment shapes and how they match different forces. But we can go later on and cover them again. But we need to check each type of attachment. And for example, if I'm extruding the tooth, I'm going to go for the extrusive attachment. Also, if I'm rotating a tooth and, for example, I'm retracting it, I know rotation is more difficult, so I'm going to go for the rotational attachment. So also, when you have multiple movements happening out throughout the treatment on a certain tooth, I pick the attachment based on the most difficult or unpredictable movement. Also, I need to check if we have size and a certain discrepancy in the size. If the attachment is too small, it's not going to be providing enough anchorage for the tooth, or providing enough surface for the aligner to apply force on the tooth. So I need to check the size and the location. I always prefer the location to be towards the direction of movement. So for example, if I am rotating tooth to the mesial end rotation, I prefer the attachment to be more on the mesio-incisal place of the tooth itself, to make sure that the movement is happening at the right direction, and the attachment is serving us in an appropriate manner. I also need to check for attachment restriction. So when I'm applying, I need to put some restriction when I'm submitting a case. If I have a crown or a bridge, and I know, or for example, if the patient has any veneers, and I'm going to know that placing attachments and removing attachments is going to be a hefty process, and the attachments is not that needed, we can remove any attachments that don't serve a purpose. Of course, always too many attachments is going to be annoying to the patient, and too many attachments is going to make the aligner too retentive and hard to remove. So we need to find the balance between too few attachments and too many attachments. And lastly, we need to check for interferences. This is something that technicians miss a lot when they're designing treatment setups, is that they don't pay notice that the attachment might be interfering with the opposing arch and causing a block on the bite. This is going to feel like a high restoration for the patient, and it's going to be pretty annoying, and maybe sometimes it causes occlusal trauma to teeth because of the interference and the high surface of the attachment that is interfering with the opposing arch. So let's remember, we have these attachments. The horizontal attachments are good when we are basically expanding the posterior segment, when we're moving them in a buccolingual direction. The horizontal attachments are the perfect attachments for that. And also for purposes of retention and anchorage, we also add passive horizontal attachments. For vertical attachments, they're mostly needed either in rotation. For canines, sometimes I prefer, when I'm rotating a canine, is to use a vertical attachment, because it gives that long, bulky support that we need. And also, whenever we're moving the teeth mesiodistally, so if I'm moving a teeth in a mesiodistal bodily direction, I'm going to need a long surface to apply forces on, and this is where the vertical attachments come into advantage. Also, for rotation of premolars, the rotational attachments provide a good shape and bevel for the, let's say, for the aligner to apply force on. We have also the oblique or sash attachments. They have different names according to the manufacturer. These are the perfect attachments for lateral incisors, whenever we're doing either rotation or extrusion on a lateral incisor. And we've mentioned before that lateral incisors are one of the most difficult teeth to apply forces on because of their small size. An oblique attachment or a sash attachment is perfect. Also for central incisors, this is strictly for central incisors, upper centrals. I think root control attachments are the most perfect to apply this coupled mechanics or coupled force to the tooth itself. And whenever we're extruding teeth other than the lateral attachment, we can use the extrusive attachment, which is basically similar to the oblique attachment, but it's placed in a horizontal manner. You can go ahead and screenshot this table if you want this guide to learn how each movement would be required for different attachments. Moving on, the fifth thing that we need to check in our treatment setup or from our list is the interproximal reduction. We need to check timing and accessibility. So sometimes, a lot of the times actually, technicians place interproximal reduction at stages where the contact is not perfect. And if we actually do that, we're gonna end up either causing a ledge on the tooth, or we're gonna end up cutting enamel from an inappropriate surface, whether it was lingual or buccal. A very useful tool to use in cases where we have like when the contact is not perfect between teeth and I'm gonna need the space early on, I need the interproximal reduction. I can get something called one-sided interproximal strips. So these are strips that cut only from one side. So if I want to avoid cutting enamel from a certain tooth, but the contact is perfect on the other tooth, I can like cut enamel from the right place I want. I can use these single-sided strips. Also, I need to check for the amount. If I do too little of interproximal reduction, I'm gonna get loss of tracking and unfavorable intrusion on teeth. So I always say getting residual spaces is always easier to fix than having no spaces. I always go a little bit more to the safer side, and I go for more interproximal reduction, because if I end with residual spaces, I can just fix that with a refinement of 5 or 6 aligners, retract the teeth and close the spaces. But if I don't have enough space, I'm gonna get loss of tracking, and I'm gonna need a mid-course adjustment, and sometimes I'm gonna get intruded teeth that are going to be difficult to fix. For example, over here, I'm gonna check that the contact between let the video just go. So we have a mistake here, because in the final result, the technician wants to reach a proper contact between the canine and the lower right premolar over here. So they end up doing a collision between the teeth. And because the technician is not experienced clinically, they add the interproximal reduction at step 1. Of course, a lot of technicians are more qualified and mastered at these things because they have a lot of experience. But I'm saying in general, because you are the treating physician and you're the dentist that controlling the case, it's always good to keep that in mind to avoid any mistakes or leaving things that go through the cracks. So lastly, after checking everything, we check the alignment, the final stage that I want to reach. Just make sure to turn on the grid. So there is a tool that many clear aligner providers have is the grid, and this is supposed to be like a real life measure of the angle of the leveling of the teeth. It's going to help you tell if you're going to end with perfect alignment and perfect leveling of the teeth or not. So that was all for our lecture today on how to review a treatment setup. I hope you were able to pick up some things that you can apply directly in your practice. And if you can check here over the slide, these are the references. If you want to go over them and find more knowledge about this, this is going to be really helpful. Thank you all for attending today.